But now, please let me introduce our next speaker. Our next speaker who is going to deliver the Geoffrey Kaye Oration, Mark Sinclair. Mark is our current Australian Society of Anaesthetists President, and he's in private practice in the Wakefield, with the Wakefield Anaesthesia Group in Adelaide. He spent 20 years as a VMO in the Flinders Medical Centre and initially worked in general practice, but later switched to anaesthesia and completed his training in Adelaide and in Edinburgh, Scotland. Mark has been a member of the South Australian and Northern Territory Committee of Management of the ASA since 2001. You get less for murder. And he was the convener of the 68th ASA National Scientific Congress in Darwin in 2009. He's probably best known as, and has contributed most before he became president, as the Economics Advisory Committee chair, a committee which he chaired from 2010 to 2021. While in this role, he served as a council-elected board member from 2016 to 2021, and he is a graduate of the Australian Institute of Company Directors. He was Vice President of the ASA from 2021 and 2023, and has been President since October. My personal suspicion is that he's counting the hours since he hands over that baton, but before we allow him to do that, he's going to deliver the Geoffrey Kaye Oration. Thank you, Mark.
Right, thank you very much, Vita, for those words, and thank you everybody for coming along to this session. There we go. The theme of the conference, of course, is Come Together, and you'll see from the title that I included in the program, I've said Come Together in the face of the threats we may face. My message also, though, which I didn't actually have in the program, is stay together in the face of these possible threats to our profession in the future. Now, when I do address these so-called threats in a short time, you'll certainly see that they are nothing new. They've been there for a while. But I've just felt that over the last few years in my role in the ASA, they've started to gel a bit more into a more real form. And so that's why I wanted to address them today specifically. But firstly, the Geoffrey Kaye Oration can, of course, by definition, only be given every second year or so. And so apologies to those who've been to a lot of NSCs, but some of you who aren't at the NSC that often, thanks for being here for this one, may not have heard much about Geoffrey Kaye, so I thought I'd introduce him. I'll also pop a few comments up that my esteemed colleagues in the past as president of the ASA have had to say about Geoffrey Kaye. My apologies to my past president colleagues in the audience who won't all get a mention, just a couple of interesting points that some of my predecessors have made. Geoffrey Kaye was a pioneer of anaesthesia in Australia and one of the key figures in turning our specialty from a bit of a hit and miss affair in the 1930s when he first started actively working into the vibrant, major, important medical specialty it is today and that we all enjoy practising. This is the Hadley Hotel in Hobart. This is a picture not from 1934, which I'm going to talk about in a second because you can see the Valiant station wagon and the Holden Ute there, but it was one that I just lifted off the ASA website because I thought it was a nice picture. But at that hotel in January 1934, there was a meeting of the British Medical Association. At that stage, there was no AMA. We were a branch of the British Medical Association. And a number of gentlemen, sorry for the sexist tone, but there were very few women practising in medicine, of course, in those days. In January 1934, 7 men got together and decided to take this specialty of anaesthesia and make a formal group out of it in order to facilitate communication and research and teaching and development and technology into a proper specialty rather than, as I said, the fairly hit and miss affair it was. And those were the 7 people involved. Geoffrey Kaye became the first secretary of what then became the Australian Society of Anaesthetists, and those names, of course, I'm sure are familiar to many of you, especially our first 3 presidents. And these men were basically the formation of the ASA and the start of developing us into the specialty we are today. Geoffrey Kaye himself, what was he? Well, he was an anaesthetist, he was an author, he was a teacher, all of these aspects of his life that I've put up there. Importantly, he was also a great servant of the Faculty of Anaesthetists, later the Australian New Zealand College of Anaesthetists, and received their Robert Orton Medal, the highest individual award of the college. And he was an ASA Life member, the highest individual award from us. Why Geoffrey Kaye? Well, after his passing in 1986, the ASA decided that all future outgoing addresses by the President, every NSC back then there was an outgoing address by the outgoing President, would be named the Geoffrey Kaye Oration in his honour because of his contributions to our specialty. And the very first Geoffrey Kaye lecture was given by Dr. Ben Barry in 1988. I put a reference up there. That very first Geoffrey Kaye Oration was made into an article in our journal. That's the reference there. By all means, take photographs if you want. You should have a look at it. It's a very interesting story, not only about Geoffrey Kaye and some of his flaws, which I'll also address, and some of his difficulties, but it's also a bit of an interesting look into the early development of anaesthesia as a specialty in Australia. Associate Professor David Scott, one of my esteemed past President colleagues, mentioned one other aspect that I hadn't been aware of about Dr. Kaye, and that is that he was also a military man. He served in the Australian Army in the 1930s, was their advisor on matters related to anaesthesia, and in fact was deployed in the Middle East for a while in the 1930s. That rang a bell with Dave, of course, because Dave himself has a long and distinguished history of service to the Australian military, where he currently holds the rank, very senior rank, of Group Captain in the Air Force. This was the home of Dr. Geoffrey Kaye. It still stands today in Mathura Avenue, Toorak in Melbourne. It was Geoffrey Kaye's home, and as you can see, this is one of the aspects of Geoffrey Kaye's life which perhaps caused some trickiness, is that he was a man of independent wealth. He did not need to practice anaesthesia day to day to make a living, like so many did. And this became the first headquarters of the ASA. Dr. Kaye turned his home into a series of meeting rooms and laboratory where he worked very hard on a lot of equipment and technology, which was one of his special interests. And indeed, he built up quite a collection, and later in life donated that collection to the faculty, now the college, where it still stands today as the Geoffrey Kaye Museum. Just out of interest, this is from the 2012 Real Estate Guide. This home sold in 2012 for $5.2 million. You can only imagine what it's worth today. Now, this caused some trickiness, as I was saying, in Geoffrey's life to some extent, because he was very, very focused on getting the specialty going, on teaching, on education, on research, and he tried to bring other people along with him. But in those days, to be an anaesthetist, if you were full-time, which not many were, was quite a hard way to make a living. You could only be paid for working in the private sector, doing a fee-for-service anaesthesia service, and the fee came from the surgeon. The surgeon collected a fee from the patient and gave a little bit to the anaesthetist and a little bit to the assistant, and that was it. So you were very much obliged to keep in good faith with your surgeons back then in order to keep making a living. Geoffrey Kaye did not need to do that, but he certainly respected the fact, and he knew the fact and wrote about the fact that he understood that people couldn't always give up their time to his pet projects, even though they were very important pet projects. But Geoffrey, we're told, was the sort of guy who didn't handle this sort of thing very well. He could get very angry, even to the state of petulance, when he didn't quite get people doing what he thought they should be doing. And another of my esteemed past colleagues, Dr. Guy Christie-Taylor, in his Geoffrey Kaye Oration, he concentrated a lot in his talk on culture, the culture of the workplace, the culture of organisations. And he made a reference to the fact that there were some controversies about Dr. Kaye's life and work, and that perhaps he didn't have a very good understanding of culture. But nevertheless, what that ended up resulting in was Geoffrey Kaye removing himself from association with the ASA for many years, and that was a bit of a controversy at the time. He also became involved initially against the idea of a faculty of anaesthetists within the College of Surgeons, but later he came to be a very excellent servant of that faculty, as I've said. But he did, in later life, get back together with the ASA. And this is a picture from 1984 in Sydney, when Sydney hosted an international meeting to mark the 50th anniversary, 1934 to 1984, of the Society. That's Dr. Kaye in the middle, and there's some other familiar faces there too, of course. On the left you have Dr. Richard Bailey, ASA Life Member, our highest award, and of course the library at our headquarters in northern Sydney is named after him, the Richard Bailey Library, an amazing collection of books and journals and other artefacts. Next to him is Professor Tess Cramond, herself a Robert Orton medalist, highest award of the college, with Dr. Kaye, and also Dr. Judy Williams and Dr. Joseph Ruprecht, with some pretty cool satchels there too from the 1984 meeting. We don't seem to have those anymore, but that's fine. So anyway, on to what I was going to talk about, the possible threats we may face as a specialty. At workforce, I'll talk about. I'll also talk about scope of practice, which may or may not be called task substitution, and also USA-style managed care in the private sector. Now again, I refer to another of my esteemed past president colleagues, Dr. Richard Gutzner, who in his Geoffrey Kaye Oration spent most of the talk on workforce. Now, the topic of workforce, the topic of task substitution, the topic of managed care could themselves each be a topic of a full talk, so I'm going to be pretty quickly zip through them. But there could even be a half-day seminar on these issues. But Dr. Gutzner talked about workforce issues, and back then, when he was president, we probably were in a situation, or seemed to be in a situation, where we were in oversupply of anaesthetists, or that was the feeling at the time. A survey at that time revealed that younger anaesthetists thought they weren't getting enough work. More anaesthetists wanted more work than they were getting. And depending on your age, many people thought there were too many new anaesthetists, and indeed we heard anecdotes of new anaesthetists working as baristas because they couldn't get the job. There was certainly still a distribution problem. If you wanted to work in the rural areas, you'd be fine, just like you would today. But there was certainly that feeling that there was an oversupply. And governments were wanting to decrease the number of doctors, probably largely for cost reasons, and it was noted at that stage by our survey as well as by government that there were more anaesthetists per head of population than there had been ever before. And that's the graphic from Richard's presentation, which shows that we went from 20 years before that, a level of 1 anaesthetist per 10,000 population, down to 1 anaesthetist for less than 6,000. And so there was a feeling of oversupply, but yet at the same time, the college some years earlier had put out this is I think March 2009 edition of the Bulletin. I'm sorry, you may not be able to see that too well, but if over to the right, the prediction at that stage was, worst case scenario, we would be 2,000 anaesthetists short by the year 2028. This study, which again, it's available on the web. If you'd like a copy, it's easy to find. I've got a copy right here with me. If you want to get it off me, please do approach me. But it was a joint effort between the ASA, the college, and Access Economics, now known as Deloitte Access Economics. So it wasn't just a simple member survey. There was a lot of work went into this, and so there was a real concern that later in this century we'd have a real shortage of anaesthetists. And, sorry, there we go. But what about now, 10 or 12 years later? We were starting to get very much the feeling, of course, and I'm sure you all agree, that perhaps anaesthetists were in undersupply. We're all perhaps working harder than we want to. This demand is increasing all the time. And so in 2022, going on through 2023, we made the decision to engage an expert group, the Health Consult Group, in another analysis of the anaesthesia workforce. This report, again, is available on the ASA website in full. I won't go into the details today, of course. I've also got it on this machine here with me if you want a copy. And that one main sort of graphic from that publication is this one, which shows the yellow line shows the anticipated demand for anaesthesia services. The blue line shows the anticipated increase in numbers of specialist anaesthetists over that time. You can see that's increasing, but the yellow line's increasing more as the population gets older, sicker, etc. And along the bottom there, you've got the predicted shortfall in full-time equivalent anaesthetists, close to 350, we're saying, by 2032. Not quite the same as the worst-case scenario described by the college some years earlier, but nevertheless a significant issue. And recommendations to come out of that were that we probably needed, from now through to 2032 and onwards, about 56 new anaesthesia trainees to be employed per year. Now that sounds like a lot, but there are about 150 accredited training locations by the college around Australia, so it's not that much really when you think about it. And that would actually been predicted by the mathematical modelling to solve the issue. Of course, we also had recommendations that we get more trainees out to the rural and regional areas, and of course more GP anaesthetists. And when I talk about scope of practice role substitution, of course, what we want to see is doctors giving the anaesthetics, and GP anaesthetists do a great job in certain parts of the country. We certainly have, I'm told in more recent times, I've been told, we have a number of non-committed hospital-based younger doctors, often referred to as CMOs or career medical officers. They also, they're already in the hospital system being paid, and they also will possibly be a source of future trainees. Anaesthesia remains a very popular choice as a possible future career among our junior doctors. And of course, what the government tries to solve these problems. Of course, they are aware of the issues. Specialist international medical graduates, that's been a big topic in recent times. Of course, what's happened is that, to some extent, the idea of accrediting international medical graduates as specialist anaesthetists in Australia has been taken over to an extent by government, and AHPRA being given the role to do that. Now, we've discussed this with AHPRA, and in fairness to them, they say this is a government initiative. We are a government body. We have to do what the government tells us to do. And so they have taken this on this expedited specialist pathway, which essentially bypasses the college. We, the psychiatrists, the GPs and the O&G guys, were all identified as areas of need for more international medical graduates. And so they at the moment are looking at pretty much automatically accrediting international medical graduates from countries that have a substantially equivalent or similar pathway for training and expertise. And that at the moment is the UK and Ireland as the only places where we're actually accepting people from at the moment. What about the supervisory requirements? Well, the supervisor, each of these international medical graduates has to be supervised for a period of 6 months, and the supervisor is simply appointed by the medical board, and all they need to have is 12 months registration as a specialist anaesthetist. They do not have to be fanskers, they just have to be registered as a specialist. And compare this to the college pathway, where of course the supervisors of these doctors are most definitely fanskers, and furthermore, there is an independent two-person workplace-based assessment run by the college to assure these folks are up to the standard we want. What about medico-legal liability? We are told that if you, as a supervisor, pass an international graduate and then a patient goes on to harm or worse, you would have some liability possibly for that, and you need medico-legal liability cover for that. Now, if you're doing it with the college, you have that cover. When we asked AHPRA, what about your supervised, your doctor supervisors that you appoint, they basically said, not our problem. So that's an outstanding issue as well that needs to be solved. As of the 31st of August, I hope my figures aren't too out of date. Our college people will correct me, no doubt, if I'm wrong. There were only 11 anaesthetists had been approved by this pathway. I'm not sure who they are or where they are. There were rumours they were going to be encouraged to go to rural areas, which we all think is a pretty bad idea, new to the country, heading out to a smaller area with very little support or knowledge of the local community. So at the moment, I'm not sure where they are or who they are. And that's what's happening with the other specialties as well. Quite a few GPs have been approved through this pathway, as you can see. Hearing from Dr. Tanya Salak, College Vice President, who's here with us at the meeting. Professor Dave Story has an apology because he's at his son's wedding, I think, today. So that's a fair enough reason, but thank you to Dr. Salak for attending. I heard from her the other day that at the same time this has been going on, 80 anaesthetists have been approved by the proper college pathway, which is a bit of an interesting comparison. Thought I'd just show you this map. We have to think about the ethics of encouraging doctors from other countries to come here and work in Australia. Of course, we welcome them with open arms if they are qualified, and I'm sure they do provide excellent service. But this is from the WFSA, the World Federation of Societies of Anaesthesiologists website. I'll show you the reference in a sec. Essentially, it shows each country around the world where they have the data how many physician anaesthesiologists, that is doctors who are practising anaesthetists, have in each country per head of population. Dark green is good, medium green's not so good, light green's getting very dicey, and of course red, yellow and orange are where there are a real problem, where there simply are nowhere near enough physician anaesthesiologists to provide a full service, and in some cases none. As you can see, Australia's dark green, so we're, comparatively speaking, even though we have challenges, we're doing very well compared to some parts of the world, and parts of the world where we might be thinking of taking anaesthesiologists from are not doing so well. So we do really, I think, have to look at the ethics of that. And there's the reference, if you want to see that map, when you hover your cursor over it, actually shows you the numbers. It's quite cool. Anyway, moving on from there, because of course one of the workforce solutions, well, we've got lots of, we do a very good job as an anaesthetist in Australia and New Zealand, and we have very good outcomes, so therefore it must be easy and anybody can do it, and that's the sort of line we've faced. I'm sure you have too. But it leads on to the scope of practice argument, which we might also call task substitution. A quick look at the USA, where you may well be aware, but the nurse practitioner model of care is very widespread, and they have a lot of nurse practitioners out there. They're extremely politically active, and they're pushing for independent practice, which has been granted, and I could be out of date, in 23 states in the USA. These are general nurse practitioners. By number, most of them, of course, are in primary care, but they are also doing specialty work such as mental health and endocrinology, I can think of as examples. And they're pushing very hard for independent practice. The political arm of the nursing federations over there are very active. They lobby regularly to the USA legislators, and indeed some of them become elected representatives. One of their arguments was that if they have more nurse practitioners, there might be better services provided to rural areas, and indeed that is the case in Australia. We do have a number of very good nurse practitioners providing excellent services in rural and remote areas where there aren't enough doctors. But the studies or the evidence shows that's not the case. They stay in the cities where they can make good incomes, and indeed there are entire companies of nurse practitioner sort of entrepreneurs who set up websites training nurse practitioners in how to make a lot of money. And of course they charge them a lot of money for access to that training. And is it cheaper? The evidence, that's what we keep getting told. If we employ lesser trained professionals as anaesthesiologists, as it is over there, they might be cheaper. Well, certainly in terms of the general nurse practitioner workforce, the evidence shows they are not. They order more tests and x-rays. They make more referrals to other healthcare practitioners. It appears that they simply don't have the same clinical acumen and confidence to practice independently as a fully qualified doctor would have. Is it safer? The nurse practitioner lobby will quote studies again and again showing that the studies show that nurse practitioners are just as good or maybe even better than their doctor equivalents. But there is no study that shows that. Every study they refer to shows nurse practitioners in exactly the model we want to see, which is a team model with a doctor at the head and the nurse practitioner providing ongoing care. Classic examples include one study which was a patient series of patients who had diabetes and or high blood pressure. Already diagnosed, already differentiated, not nurse practitioners taking on undifferentiated patients independently. And those studies did show that when in a team-based model that I'm talking about, patients receive excellent care with the nurse practitioner taking on the role of ongoing monitoring, ongoing education and liaising with other members of the team, especially the doctor, if there are issues. And that's the only study evidence there is. I could be out of date, but certainly as of earlier this year, there was no study showing independent nurse practitioners, which is what they want, are cheaper, safer. And, but there are certainly plenty of anecdotes of absolute disasters, so I'll go on more about that in a second. What about the CRNA, the anaesthesia situation? Well, the Certified Registered Nurse Anaesthetist, or anaesthetist as they pronounce it over there, it's a bit better, the training there, than some of the nurse practitioner training schemes, which are basically a lot of online stuff, very little clinical care. I'm hearing figures of 5% of the hours that a doctor would spend becoming a specialist doctor. But the nursing anaesthetists have to do a bachelor degree in nursing, at least a year in critical care, which I think can include A&E, a 3-year course followed by an exam. But mostly still in a supervised model. However, they too wish to go on to have independent practice rights, and they wish to refer to themselves no longer as nurse anaesthetists, but as nurse anaesthesiologists. Our ASA USA is obviously leading the fight against that. PhDs are also made available to these folks so that they then call themselves doctor. And these PhDs aren't what you expect from an Australian university. They're often online and they cost a bit of money, and universities make a lot of money out of them. But once they've got a PhD, of course, they can then call themselves Dr. John Smith, nurse, anaesthesiologist. There's a real move in the USA from our colleagues over there to make sure that people identify themselves properly, because in all of the cases of bad outcomes, pretty much, the patient was totally unaware that this person in scrubs, in a white coat, with a stethoscope around their neck, their name emblazoned on their white coat, and calling themselves Dr. John Smith, was actually a nurse. In the UK, of course, we've all heard of the situation in Anaesthesia Associates, and I refer you to an article very kindly provided to us by their president, Dr. Tim Meek, in our March edition of Australian Anaesthetist. This goes back to the early 2000s with the idea of the Anaesthesia Associate, an operating theatre technician or similar being trained up in basic anaesthesia provision. It was very haphazard at the start, really just under local governance, all unregulated. But much later, they started thinking, well, perhaps we ought to do something about this and have a proper course. So they do a 2-year university course while working as a trainee in the hospital system as well. By the middle of last decade, there were approximately 200 of these folks. The UK government decided that by the middle of this decade we want 2,000 of them, and of course that caused a lot of controversy, as you can imagine. There are only limited training resources in hospitals. There were concerns about our registrar colleagues in Britain not getting enough training time, and of course also the economics of this. You have to pay these people, of course, and unless you pay them a lot less than an anaesthetist, the economics don't work out. So there was a review of this commissioned by Professor Leng in 2024. She was previously the CEO of NICE, the institute I'm sure you've all heard of. And one of the recommendations there was that there would be a renaming of this profession into physician assistants rather than physician associates, which seems more like a doctor's title. And specifically for anaesthesia, that they should be called PAAs. And that also their ongoing training and monitoring should be under the Royal College of Anaesthetists, which is obviously a very wise thing. But there's still a lot going on in this space, and still some controversy there. So have a look at Dr. Meek's article. But in Australia, it's underway in a formal process. This is the Cormac review. Again, I've got the document on here if you want it. 150 pages, so I'm not going to do much with it today except show you some of it. Essentially, it's run by Professor Mark Cormac, who's a professor at the ANU and is former CEO of Health Workforce Australia. The recommendations coming out of that are largely to do with primary care, that we should be encouraging and enabling and facilitating lesser trained health practitioners than GPs to work in a multidisciplinary arrangement and with them working to their full scope of practice and assisting in primary care. And the report made 18 recommendations, which are here, sorry, I know it's busy. They're all basically pretty good recommendations, about training and monitoring and so forth, and encouraging people to work in a multidisciplinary environment. But I wanted you to look at recommendation 11 specifically, and this to me speaks to the ongoing agenda that it's not just going to be about primary care, and it is going to extend. Recommendation 11 is to introduce a bundled payment for maternity care. Now, I don't quite know what that's got to do with general practice, except they did say that, of course, 9 months of maternity care does cross the line over into primary care for some of that time. Well, so does a hernia repair. That crosses the line into general practice as well, with GPs looking after those patients and referring them to surgeons. So this, to me, speaks to an ongoing agenda of broadening this at some stage. What does the Cochrane Library have to say about nurse anaesthetists or nurse practitioners giving anaesthetics? The only article at the moment comes from 2014. That's the reference. By all means, take photographs. Again, I think I've got it on here if you do want the actual paper. What did they find? They looked at thousands of studies. I could only consider 6 of them because most of the studies were loaded with bias and other issues. And of those 6 studies, none were RCTs, and they all had, or in the minds of the reviewers, some unacceptable levels of bias and sources of funding and so forth. All they could really say was that the data isn't there. Basically, that's what that slide says. The data isn't there, we just don't have the data. And so we can't make any meaningful recommendations there. And also they mentioned, of course, the confounding from the funding sources. So what did the American Association of Nurse Anaesthetists have to say about that? Again, a very politically active group. No difference. Studies have shown there's no difference between the care provided by physician anaesthesiologists and nurse anaesthetists. That is not what that study said. They just said there isn't the data. We don't have the data. And so we can't make a meaningful conclusion. But that's the line they're pushing in America. And as I said, they're very politically active. They themselves become politicians. And that's the line they're pushing when it comes to independent nurse anaesthetist practice. What does the WHO have to say? World Health Organisation, in conjunction with the WFSA in 2018, they put out some recommendations about safe practice of anaesthesia and essentially said that wherever possible, I mean, no, it's not always possible, wherever possible, anaesthesia care should be led by a physician, and that came in at the level of highly recommended. I'll go on to managed care in a sec, but the American Patient Safety Foundation, sorry, I didn't do a slide about that, but the American Patient Safety Foundation, largely involving the American ASA as well as the nurse anaesthetists, who do a lot of work on patient safety in anaesthesia and surgery, they included that statement in their, on their website and in their output, which led immediately to the nurse anaesthetists removing their funding from that safety foundation. So, of course, never let the facts get in the way of what you want to achieve. So managed care, what is it? That's the definition, but a few key points there. It's dominant in the USA, control costs, improve quality maybe, through a network, and that's a good one, a network of contracted providers, and control of utilisation. That's what managed care is defined as. And of course it puts a lot of power and control in the hands of the insurers over there. Several layers of bureaucracy, I'll detail that in a sec, but of course what it does is limit choice, limits the choice of doctors to refer to other doctors, limits the choice of patients to which doctor they can have and where they have their care. And of course it's all about profits. Looking at the profits, one of the big companies over there, United Healthcare, that's their profit from the year before last, I think, 25 billion. That puts them 5th of all companies in America, behind some very famous company names there. That's the sort of profits these companies are generating over there with their managed care system. The big one, of course, that causes a lot of nuisance to doctors is the prior authorisation. On average, this is across all doctors, not just anaesthesiologists, pre-authorisations are over 40 a week, and it takes 14 hours per doctor per week to go through prior authorisations, getting authorisation from the insurance company to pay for that care. Imagine a practice of 20 doctors and you start to see they have several full-time employees, some of these practices, purely working on health insurance requirements. And in hospitals, you'll have entire wings devoted to just dealing with private health insurers and getting authorisation for care. That again, if by all means take photographs, that comes from the American AMA in 2023, those numbers. But back here in Australia, another of my esteemed predecessors, Dr. Susie New, of course you'll all be aware, has put a number of podcasts up on our website. I commend those to your listening. They're all excellent, but she had a number of interesting ones on this managed care scenario. Number 36, which was an interview of Dr. Peter Waterhouse, our retired now Professional Issues Advisory Committee chair. He talked with Susie about the Honeysuckle Healthcare, which I'm sure you're all familiar with if you're in private practice, was a joint initiative between NIB and another massive multi-billion-dollar profitable company in the USA, Cigna. And that was a situation which you're all familiar with, where they would provide a better no-gap arrangement or a better known-gap arrangement for patient fees, lifting what they would pay to the doctor, provided they signed a 4-page contract with various requirements in it, some of which were a bit of a concern. And it looked like they were really trying to get more control over a team of doctors, possibly a preferred provider network. Also, episode number 38, Dr. Carmen Brown, who is an O&G specialist, I think in Victoria now, full-time staffy, but she did train and practice for some years in the USA and became extremely frustrated at the managed care system over there, and as a result actually gave up practice there for a while and eventually moved to Australia, where she's now very happy in her practice here in Australia. She talked a bit about the preferred provider network and what a problem that was causing. And the fact that you had hospital networks, doctor networks and so forth. One quote I remember very well from her podcast was that the words health insurance, health care and profit should never be mentioned in the same sentence. I'll show you some of the Australian profitability in a sec. And I agree with that. Perhaps I'll be slightly controversial and say that healthcare is not the most important thing in your life. It's the only thing in your life, your health. Doesn't matter how rich you are, how powerful you are, how famous you are. If you don't have your health, you have a miserable life. And I quite agree that you should not be talking about profits when it comes to health insurance. We do have a number of not-for-profit insurers in Australia, of course. And another episode, number 45, she talks with a nurse and midwife from the USA. So I couldn't catch her name on that podcast, but she talked about a patient who had Barrett's esophagus, and as we know, that should mean an endoscopy every year or so. He wasn't getting that because the insurance company refused to fund it. This is a friend of hers, sorry, not her herself. Ended up with stage 4 esophageal cancer, and the insurance company refused to fund that at first because he was too far gone and it wasn't worth money spending on him to try and retrieve the situation. He did end up having treatment, and at last I heard was okay. And so her other situation was she was out on holiday with her daughter who had some sort of anaphylactic reaction to something, we don't know what, and had the experience of going to a hospital which was not within her insurance company's network, and a bill of thousands and thousands of dollars in an emergency like that. And it happened a couple of times actually on the same trip, so it was a bit of a nasty situation. But that's what happens when you have insurers in charge of who goes to which doctor at which facility. And last one of Susie's podcasts I'll refer to, when she interviews Dr. Zane Upton, who is an anaesthetist in her Talking Money site. Dr. Upton started work in his life training to be an insurance company actuary, which is interesting, but he ended up not liking that and deciding he would go to medical school instead, which he did, and later became a specialist anaesthetist. And he talks about the aims of for-profit health insurers, because he's obviously has expertise in that area. Health insurers are looking at the long term. They're not looking at next year or the year after when it comes to their ongoing profitability. They're looking at the next decade or 2 decades, and that's why I'm concerned that what we're seeing, this gradual sort of gelling of managed care or control type situations, is going to keep going forward. I asked the Americans, we meet regularly with the Americans, the Canadians, the New Zealanders, the South Africans and the British with our leadership teams of the associations of anaesthesia in those countries, and I asked the Americans, and my predecessors have too, what would you have done differently if you had your time again? Because this goes back 30 years. First of all, they said, no more Mr. Nice Guy. When insurance companies were first doing this sort of thing and first trying to get that sort of control, the American anaesthesiologists tried to work with them and tried to do a team type situation, and of course it all went very poorly. And the other thing they said they would also do, I heard them say, was egregious billing behaviours by a very small percentage of doctors being seized upon, of course, by health insurers and sometimes political people and their lobbyists. And does that sound familiar? It's the sort of thing we're seeing here, isn't it? Occasional egregious behaviours by some of our doctors, which we need to try and stop, because that was one sort of key in the door for the insurers to get this program up and running. In Australia, we have for-profit private health insurers, of course. They cover now over 80% of the insured population in Australia, and their profitability is very good. 2.13 billion in total for that financial year. Again, please don't get me wrong, I'm not against companies making a profit. I'm a pure capitalist myself. If they want to make profits, by all means, car insurance, home and contents insurance, life insurance, income protection insurance. Oh boy, I'm producing plenty of profits, so I can tell you for my insurer out of my premiums for income protection these days. But healthcare should be free of that, I believe, and I'm sure some of you will agree. And we probably should support better our not-for-profit insurers. And of course, the other aspect of which I haven't put on the slide is that in recent years, it used to be that insurers return 90% of those premiums paid by you into your care. Now it's dropped down to about 84%. 6 percentage points doesn't sound a lot, but that represents billions of dollars not being spent on healthcare. And looking at some of their profitability, where it's going the last 4 or 5 years, they're constantly complaining that they're spending too much on doctors and they're spending too much on technology and appliances and prostheses. They're spending too much on hospitals. Well, looking at that slide, they're spending a hell of a lot on management expenses. That's grown massively over the last few years. And of course, they're also making some very healthy profits that have been increasing as well. Anyway, so that's just a touch on what's going on in Australia at the moment. I hope it's been a very quick ride through that, so excuse me for that, but they are very big topics. As I said, they could each become the topic of a half-day seminar. But we need to watch out, we need to work together, we need to come together as the theme of this conference, but we need to stay together when it comes to these issues. And that's all I have to say. Thank you very much. There's our contact details. Come see me if you want any of those documents. Thank you very much.